Second step, determination of the electrical heart axis. There are several ways to determine the electrical heart axis. A simple one for the heart axis in the frontal plane is to take lead 1, that goes from right arm to left arm, as you can see in the figure, and AVF, that goes down. Then we take the net result of the deflection of lead 1. So, for instance, in this case, the positive deflection is 7 millimeters, the negative deflection 3 millimeters, so the net result is 4 millimeters, and that 4 millimeters we draw on lead 1 to the right side because it's positive. The same we do in AVF, and let's say the net result is 3 millimeters positive, and we draw that on lead AVF downwards because in the positive direction. Then we define the vector, and we have the heart axis in the frontal plane. We express heart axis in degrees. When it's going to the left side of the body in the direction of lead 1, we call it 0 degrees. When it's going straight up, minus 90 degrees. When it goes straight down, plus 90 degrees. And when it goes to the right, plus or minus 180 degrees. When it lies between minus 30 degrees and plus 90 degrees, we call it a normal heart axis. Between plus 90 and plus 180 degrees, right heart axis. Between minus 30 and minus 90 degrees, left heart axis. And between minus 90 and plus or minus 180 degrees, we finally call it an extreme heart axis. This is a simple way, but also lead 2 can be helpful in determining the axis. When we project the Eindhoven triangle, then the perpendicular on lead 2 is exactly minus 30 degrees, so the border of normal. And when the electrical axis is positive in 2 by positive deflection in 1, we have a normal axis. And when it's negative in 2, when 1 is positive, then we have a left axis. So lead 2 differentiates between normal and left heart axis. Measuring heart axis can be helpful in detecting pathology. Right heart axis can be seen in child, in a thin adult, that's not pathology, in anterolateral myocardial infarction, in a left posterior vesicular block, in WPW with left accessory bundle, and when there is load of the right heart, right ventricular hypertrophy, lung disease, pulmonary embolism, and atrial or ventricular septal defect. Whereas a left heart axis can point to obesity or high diaphragm, to inferior infarction with Qs in 2, 3 and AVF, to a left anterior vesicular block, to WPW with a right accessory bundle, and you can see it in artificial pacemaker. At the end, some practice ECGs. There are 9 of it. look at them carefully, press the pause button, and in that ECGs we elaborate the things we have discussed before. The first one, what in this ECG is the heart axis? Therefore, we look at lead 1 and lead AVF and remember the Eindhoven triangle. And we fill in the net results of the voltages in lead 1 and AVF. And 1 is clearly negative, AVF is positive. From these two we construct the vector and we notice that there is a right heart axis. How do you see the heart axis in this ECG? Again, as learned, we take lead 1 and lead AVF, sign in the net results of the QRS complexes, and in this case lead 1 positive, lead AVF negative, define the vector, and we can see that there is a left heart axis. And additional, we look at lead 2, we see it's clearly negative, and we notice that the vector and thus the heart axis lies left from the perpendicular on lead 2. Lead 1 is positive, so there is indeed a left heart axis. And again, please your attention for the heart axis in this ECG. Lead 1 and lead AVF, QRS complex in lead 1 is clearly negative, and QRS in AVF also clearly negative. So here the vector in the right upper quadrant, and therefore an extreme heart axis.